seeing the.
So, we have a panel, and Darren will go through the members of that panel in a few moments, but I just thought I'd place this session in some context. The National Institute for Health and Care Excellence published a set of guidelines, as many of us know, on renal and ureteric stones, their assessment and management. These were published in the British Journal of Urology in January 2019 after an extensive period of consultation and paper review. Prior to publication, a response to draft guidelines was invited, and as an interested party, the committee of the section of Endourology of BAUS read the draft guidelines and as a committee submitted a response. We understand or believe that some changes were made to the final guidelines in response to our and other submissions. The committee also felt the membership of BAUS should have an opportunity to read and absorb these guidelines, and we wish for them to be discussed extensively and in open. And Darren, as Vice Chair, and I as Chair, published a blog in the British Journal of Urology with the guidelines to open that discussion. The committee also felt that they should be discussed further in an open session here at BAUS, and here we are. In the session, we hope to place those guidelines into a clinical context, and Darren will explain more about how we're going to try and achieve that. I am delighted that my predecessor as chair of section and the chair of the guidelines panel, Andrew Dickinson, is here to, again, put the guidelines into a context. I now hand over to my vice chair of the section, co-chair today, Darren Smith, who's going to guide us through the panel and how we're going to run this session. There is voting, so not phones out to have them ringing or phones out to discuss what you're having for dinner or who you're meeting where, but phones out to get access to the app, because we will be asking you some questions which we're going to want your responses to as part of the session. Darren.
Wow, it's bright here. Well, I'm a relative blog novice, so it was useful to do this together. JG as blog king. We had that published in the BJUI just the day after the NICE guidelines themselves were published, and it's good to be able to talk through them here and to thank the panel for doing so. So what we've done and what we're going to do is to discuss these. They're simple and straightforward cases. It's real-life endourology. Thanks to Wasim and Zara, who are going to take the main brunt of discussing what these cases are. So I've got some slides for who are the panel, and in particular, the background from which they come. And there's a range here. Wasim, he's a single-handed endoluminal endourologist, so he's got access to 2 stone sessions a week. He's got a lithotripta once a month. This is going to be relevant in the timing of the delivery of care, and a small population. Zara in a bigger unit, 2 stone surgeons there, between them sharing 3 lists, slightly more shockwave, more registrars, bigger population. To Dickie, speaker's gone. Just have to raise voice. Who needs no further introduction, including to those of us who are in the room when, as he's already said earlier this week, the Plymouth Dirty Laundry came out with what actually were the standards of care that's actually largely driven this process for us over the last 4 or 5 years. Incidentally, in the other comments there that he's meekly left blank, as Jonathan has just said, that's only to avoid 2 or 3 more slides, because there's pretty much nothing in endourology or British urology that Dickie either hasn't done or isn't doing, from chair of the section to chair of the education committee, audit committee, a proper giant. So we'll hand over to him in a second. Rob, who I've known for a long time from Liverpool, a genuine brain box, and he's going to talk about what is the critical evidence that lay behind the guideline. And as we put in the blog, the guideline is 35 pages or something. It's underpinned by 1,700 pages of evidence, and that's what makes it so rigorous. JG himself, in a department of about 20 urologists, he's got the greatest access to stone lists and shockwave lithotripsy, chair of the section, and now our representative on the Royal College of Surgeons. So for helping deliver this in real life practice in your units, a lot of this, hopefully, we will be able to get him to deliver too. I come from that's at 34 or so. Our unit at UCH is so big that one of the U's stands for uncertain. It might be 34. By the time I get back there tomorrow, it might be 35. But we're a relatively small unit in terms of stone surgeons, where in many units it's a quarter or a third of people doing stones. At UCH, it's just a tenth of us. So we have our issues too. With that as the background for the panel, we'll start with one question, and then I'll hand over to Dickie to talk you through the guidelines themselves.
Phones out. How many of you have read the guidelines on urinary tract stone disease? So phones out and get answering. And we should be getting, there we go. So no music accompanying this, but there's your immediate answer. So 35 or so % of you, so a third of urologists who are attending a session with an interest in NICE guidelines haven't read the NICE guidelines. That's an important context in which we place this discussion. Dickie.
Thank you very much, Darren and Jonathan, for inviting me. It's a great pleasure to come and talk to my section about the NICE guidelines that I was lucky enough to chair. I'm going to run a little bit through the process. I'm going to tell you the recommendations we made. I will go into a little bit behind the health economics, and then I will sum up with the research recommendations that the committee also made. How does it all work? It works by NHS England referring a topic to NICE. NICE doesn't actually write the guidelines, but it commissions the National Guidelines Centre to develop them. And the National Guidelines Centre was based in the Royal College of Physicians. NICE then works with the Guidelines Committee Centre and with stakeholders to identify the priorities of the scope. So we work out those questions that we want to answer. We cannot answer them all, and on average, the question cost about £22,000 to £25,000 each. So there is a limited budget, so you have to limit the number of questions that you wish to address. They appoint a chair by interview, and then the chair and the committee works together to work out who they're going to have on the committee. And it's not just surgeons or urologists. You have to have 2 lay people. You have, and on our committee, we had a nurse, we had a renal physician. Because we were also doing children, we had a paediatric urologist and a paediatric nephrologist. Had somebody from radiology and had somebody from chem pathology. Once you've got the scope done and the questions, the Guideline Centre technical team trawl all the evidence, huge numbers of papers. Those are then cut down, and the researchers then look at the evidence and produce the evidence in a tabulated form, which are then presented to the committee. The recommendations are based on the best available evidence and the cost effectiveness. That's really important. The Guideline Committee's experience and opinion of good practice is also involved. And at the end, once we've done the guidelines, they go back out to public consultation for revision and publication. This is your English lesson. And the words in NICE mean very, very specific things. So the word offer is put because the evidence is strong, so the intervention or the activity should be offered. Okay? And it trumps consider where the evidence is not so strong. That's why those 2 words are used in the recommendations. Okay, what we did, we went through these 8 priorities. So we looked at diagnostic imaging, pain management, medical expulsive therapy, stenting before treatment, surgical intervention, stenting after treatment, metabolic testing, and preventing recurrence. So I will run through the recommendations. So the first one was for diagnostic imaging. And the evidence would suggest that you offer, so that's stronger than consider, you offer an urgent, within 24 hours, CT scan to make the diagnosis. In children, you offer ultrasound first, but if there's any suspect or it hasn't given us an uncertainty, then go and do a CT. So that's fairly uncontroversial. Pain management. This is an interesting thing, and a result certainly came up that we weren't expecting. We all know that non-steroidal is probably the best, and that the evidence proved it, so you should offer a non-steroidal anti-inflammatory. But the evidence out there suggests that you should also offer intravenous paracetamol to adults and children with suspected renal colic if a non-steroidal is contraindicated or is not working. The evidence shows that IV paracetamol is significantly better for renal colic pain than opiates, almost to the point that we could almost suggest that you don't give opiates to renal colic, but that was felt to be a little bit too strong, so it should be used as the third line. But if you're getting to the opiate level, perhaps the diagnosis is not correct. So the recommendations say non-steroidals and IV paracetamol. There's no evidence out there for oral. Okay? This was a bit of a controversial and spent a lot of discussion in committee, as you can imagine. But when you do all the papers together, then an alpha blocker seems to provide some evidence, some benefit to distal ureteric stones. But it's only a consider, it's not an offer. So it is worth wondering about whether this could be the best thing to do for your patient. I know this flies slightly in the suspend trial, but when you put all the data together, it was felt by the committee that you should consider an alpha blocker. Stenting for shockwave lithotripsy. There's no evidence out there, so do not offer pre-treatment stenting. You don't need to do that for lithotripsy. There was no evidence that we could find for ureteroscopy. This is just based on shockwave lithotripsy. It's all based on the evidence that we've got out there. We can't make a recommendation if there's no evidence. Okay, surgical treatment. Renal stones. Certainly worth considering watchful waiting for asymptomatic renal stones in adults, and if it's less than 5 millimeters, or if it's larger than 5 millimeters, the same, once you've had the discussion with the patient with an informed discussion. All the way through the guidelines is the key thing about having an informed discussion with the patient. They're guidelines, they're not mandatory, but they are there for you to have a discussion and give you the evidence to back up your discussion with the patients. Now, those of you who know me quite well, I do like grids, so I was really pleased I was able to get a grid into the guidelines, because we thought this was actually the best way of doing it. This is not particularly controversial because renal stones are probably best managed by lithotripsy, so it was an offer, and then consider ureteroscopy. Whoops. We had a little bit more discussion about this group, because quite a lot of you would consider a larger renal stone to be done with a percutaneous stone removal. And in probably retrospect, but we couldn't have done it, the size that we chose was quite large, because there is quite a difference between an 11 millimeter stone and a 19 millimeter stone. But when you place the evidence and the health economics into it, you should be considering ureteroscopy or lithotripsy for this side stone initially. Ureteric stones. Okay, this is slightly more controversial. So in a ureteric stone less than 10 millimeters, you should offer lithotripsy. But consider ureteroscopy if stone clearance with lithotripsy was not possible within 4 weeks, or you couldn't see the stone, or previously had lithotripsy and it didn't work. Okay? So it's offer lithotripsy for the small stones. Ureteric stones are between 10 and 20, less controversial, offer ureteroscopy. Okay, now, some of us in the room would say, stone clearance rate, really important. And we know the stone clearance rate for ureteroscopy for a ureteric stone is around 94%. We also know, even the best standards of lithotripsy, that it's around about 83%. So why are you recommending lithotripsy, which doesn't get such a good stone-free rate? And it's because the question at the very beginning is cost effectiveness. It's very important, and with the guidelines are always very keen on this. So if you look at this slide, the bottom line, ureteroscopy strategy. In order to get the patient stone free, you're going to spend £3,252. Okay? And this was based on the papers we looked at with the evidence that we used. If you're going to go for a stone free with lithotripsy, it's going to cost you £865. A massive difference. But it's not just about the cost, it's about the cost effectiveness. And that's where quality of life and QALYs come in. Now, a QALY is quality of life in years. And there are ways that you can do this with NICE to get the two closer together using quality of life. What is the gains that we need to get the ureteroscopic strategy closer to the cost of lithotripsy? Through a variety of statistics, and I won't go into the background, you have to have a quality of life gain for ureteroscopy of 0.12. Just park that figure. That's fine, and you can do it if there's a long time scale. But remember that these two papers had treatment done every 2 weeks. So you have to see the quality of life gain in 2 weeks. And also, remember that there's only 11% of patients benefit in ureteroscopy. So the whole of your quality of life gain has to come from this 11.2%. Okay? So if you do the maths, you need a quality of life difference between the two of 27.8. Now, if any of you understand quality of life, that is impossible because the range of quality of life is minus 0.59, so that's a state worse than death, to 1. So it's not physically possible. So there's no way you can justify ureteroscopy over lithotripsy in a cost-effective model. You could argue, hang on a sec, that's the best paper we're using lithotripsy. So we remodeled it, and we had a success rate of lithotripsy around 40%, because the committee felt that was a reasonable value for the lot of the mobile machines we use in the UK. And even if you put your effectiveness for lithotripsy at 40%, and even if you then say the treatment is every 12 weeks, it still doesn't come out as cost-effective. That's why that recommendation was made. Okay, this has proved to be quite controversial. The timing of surgical treatment, we were very keen to get some form of timing into the guidelines. Very little evidence out there, but the papers we found were all done within 48 hours, and we decided that you should offer surgical treatment, ureteric stones or renal colic, within 48 hours of diagnosis if the pain is ongoing and not tolerated, or the stone is unlikely to pass. That's not everybody. It's a requirement of those two things. There is some evidence that medical expulsive therapy can help lithotripsy, so you should consider giving alpha blockers as an adjunct to lithotripsy. Stenting after ureteroscopy, there's no evidence out there that it seems to do any benefit. So you do not routinely offer post-treatment stenting to adults who have a ureteroscopy for ureteric stones less than 20 millimeters. Okay? This word, routinely, developed about a 2-hour conversation with the clinicians who know what routinely is versus the nice grammar police, as I used to call her, who don't like the word routinely. NICE do not like the word routinely because what does it mean? It was felt in the end that what routinely means is that there is no complicating factors. In other words, you haven't made a hole and you haven't got a potentially septic patient. That's the vast majority. So the take-home message is if it goes forward, it's straightforward ureteroscopy, you do not need to put a stent in at the end. Okay? Metabolics testing. There's virtually no evidence out here, but as a considered opinion of the group, we felt that you should send stone for analysis and you should measure serum calcium because that fits in with the hyperparathyroid guidelines. Okay? In children, different group, more likely to have a metabolic problem, and they should be referred to the appropriate team for a full workup. There is an awful lot of quite poor evidence out for dietary and lifestyle advice. It was difficult to sift through it, but basically what we decided that you should drink more, you should probably avoid fizzy drinks like Coke, 7-Up, that you should restrict your salt, and that there's no evidence that cutting out calcium makes a difference, and it probably makes it worse. Okay? Plus the general health, lifestyle, exercise, and weight loss. Potassium citrate seems to be beneficial, particularly in adults with stones that are predominantly more than 50% of calcium, and you should consider it in children. And again, with thiazides, you consider a thiazide in an adult with recurrent stone formation of greater than 50% calcium oxalate, having already managed their salt intake. So, as I said at the beginning, we can't do it all, and there were certain areas that were not evidenced that we decided a research recommendation was required. And particularly we thought that in metabolic assessment, there needs to be a trial to see if we really do need to do all these tests and whether there's any benefit and whether there is any cost effectiveness. There seems to be some evidence that alpha blockers may help in ureteroscopy. There seems to be some evidence that potassium citrate or a diuretic can reduce recurrence after shockwave lithotripsy. There was nothing out there on follow-up. There is no evidence out there. This is a trial waiting, I think, for the UK to do. And because the use of oral paracetamol, and because the route of non-steroidals was quite varied in the evidence, it would be nice to do a trial to see which is the best route for a non-steroidal anti-inflammatory, having said that it's the best for pain relief. They're the guidelines on the NICE website. This is the team. So you can see there's a large number of people involved. And I'd just like to thank the National Guideline Centre, who are extraordinary, and their ability to analyse, present, and discuss, and their non-medics is incredible. And they're also running 3 guidelines at the same time. So their breadth of knowledge is enormous. Thank you very much.
And Dickie, before you leave the stage, can I have one point of clarification? I know Darren's going to run it, but in the economic model, was the cost of the lithotripta, is that factored in, just out of interest? Yes or no?
No, they use the reference cost of treatment.
Right, not the cost of the...
Once you made that recommendation, the next stage that goes up, there's a whole committee in NICE that looks at the implication for the NHS. And if it's thought that the recommendation is going to cost, I think it's more than $1 million plus, then they get worried. But they didn't even, allowing for this, they felt that that ceiling wasn't reached. They appreciated that some centres were probably going to need to obtain a lithotripta, but they also felt that through networking, that the majority of patients would probably have access within a reasonable thing. So you make a recommendation, it just gets scrutinised.
Yes, no, I understand. Thank you. Darren.
There we are. So you've all read them now. 100%, you know what's in there. And as Dickie has said, they couldn't, in the year or so of meetings, answer all of the questions. In this, we're not going to go through all of those. So I've chosen these, working from a small stone to a small stone in the ureter, stent-free ureteroscopy, a medium stone, a large stone. I think the large stone is also uncontentious, and we'll touch on the follow-up if we have time at the end, and hopefully we'll also have the opportunity for a few questions. These are the ones that are particularly highlighting. When the topic of MET comes up, I look at my excellent friend, Mr. Wiseman, and go, so this, especially for you, will not be discussed. So the ones that are in blue, I think those are the ones that are the most contentious, and actually Dickie has just said the same. The time frame for ureteric colic, that's a big issue. Leaving patients unstented, for many of us in the room, I suspect that that's a very major paradigm shift to even consider it, let alone offer it, and then actually do it. And then the medium stone is interesting because that's quite a range, and a 19 millimeter stone is very nearly a large stone, and an 11 millimeter one is pretty small. So with a little bit of craning of heads, the panel will look at the pictures. They're simple, they're straightforward. It's about how these are managed. But firstly, to ask you, what is the state of the nation for a small renal stone? Phones.
So we need your phones. We have a question, which I think is now being asked. So for a renal stone less than 10 millimeters, I would either offer lithotripsy as first-line treatment or decide based on additional variables what your treatment would be. And
is the IT going to work? Can we have?
Here we
Okay.
go. And so there should be some music playing. You don't want to hear me singing but put your answers in. And
well, that's
it's going to come.
It's certainly a well-balanced answer. Interestingly, of course, both of the answers are right.
So can we go back? Do we have an answer for that? Is our IT team? Are you getting our responses, and are they being fed back to you? And do we have the true answer? No.
Okay. Should we move on?
So have one more go. Just one more go. Have one more go now. Can you start voting? There we go. It's working now. So sorry.
Yeah. Okay. Slightly less than Brexit. No, it isn't. Brilliant.
So we have a very split audience after hearing the guidelines where we should be.
Okay, so to the panel. It's a 7 millimeter lower pole stone. It's got just the right Hounsfield unit density at 750, and it's got just the right skin to stone distance at 11 centimeters. So let's go Wasim and then Zara. This is like an opening question in University Challenge, isn't it? What would you do in your unit for that stone?
Depending on the patient characteristics, I would offer 3 ways we could possibly manage this stone. One thing I will mention is that with the modern day PAC systems, you can often go back a number of years at the computer and see how long the stone's actually been there. So lots of people get CTs, X-rays, ultrasounds for various things. If you go back, say, 3-4 years and they've had a CT for abdo pain and the stone's there, that stone, if it hasn't changed, has already been actively surveyed for a period of time. So if that active surveillance is an option for this stone, then you'd have to counsel them whether they're symptomatic or not. They could have shockwave lithotripsy. It doesn't look like it's in a particularly long calyx or a particularly acute angle. You have to tell them that there are going to be a number of treatments, the stone success rates, stone clearance rates. If they're keen on a single definitive procedure, then you can also counsel them about flexible ureteroscopy. But I'd offer them one of those 3. But I think active surveillance is a good option if the patient's asymptomatic, depending on their age. And of course, if the stone's already been spotted on a scan a number of years before.
So we use a lot of different things than just the size of the stone to make the decision in real life. Very, very reasonable. Zara, what would you do?
For this particular stone, I'd aim to recruit them to the PURE study. As we all know, there's a paucity of evidence for lower pole stones, both in terms of stone clearance rates, but importantly, patient experience. And this certainly fits the bill for the first arm of the PURE study, so I'd aim to recruit them to the study. But outside of that, I agree with Wasim. I would offer conservative. I'd err towards. I'd be steering them towards treatment unless there was a good history of a long history of that stone being unchanged. At 7 millimetres, I would tend to recommend treatment rather than conservative management. But I think both flexible URS and laser and lithotripsy are reasonable options. Lithotripsy is obviously the recommendation of NICE mainly on the basis of cost, but the patient may choose flexible URS, and I would offer them both options.
And of course, that's why you're the lead contributor to the
Thank
PURE
you,
study.
yes.
Bravo. So that was the treatment strategy as discussed. Rob, what was the evidence that underlay the decision?
So NICE have done meta-analyses looking at randomized controlled trials and also teased out the data in each subgroup where it was all grouped together. And they've recommended for this offer shockwave lithotripsy or consider ureteroscopy if there are contraindications, if the patients had previous failed course of lithotripsy for a previous stone, or, and it is mentioned in here, because of anatomical reasons. So it is in there. It is a guideline. In terms of the, if we just move to the next slide, in terms of what the stone-free rate showed, it was high for both. So the 4 RCTs that compared outcomes for stones less than 10 millimeters lithotripsy versus versus FIRS, the success rate for litho was around 85%, and it was around 90% for ureteroscopy for these stones in the kidney. It wasn't quite significant, the difference between the two for this group. It was close. For retreatment, obviously there is more retreatment for lithotripsy, which is the forest plot below. And if we go on to the next slide, so NICE had a long discussion about how we dealt with complications, because the complications are different for lithotripsy and for ureteroscopy. Some of them are quite procedure specific. So what we ended up doing was to divide them into minor complications, which was Clavian 1 and 2, and major complications, which was 3 and 4. And for the minor complications, minor adverse events, lithotripsy came out better than ureteroscopy. So that's what the evidence shows for this.
So maybe we sat on the stone, maybe it's a different patient, but so now it's not in the kidney anymore. It's still, let's call it still a 7 millimeter stone. The patient now presents to A&E in ureteric colic, and these are nice pictures. I use these in my FRCS role teaching and say, what is that? It's in the stomach, it's a pill, that's not morphine. This is from years ago. We were already giving oral and PR analgesia. So that's a pill in the stomach for the hydronephrotic right kidney, secondary to a 7 millimeter stone in the upper ureter. Treatment strategies, let's go Zara, Wasim, and then we'll have the evidence. What would you do for, so this is a patient, they're in pain, they've got a 7 millimeter proximal ureteric stone, they've had first line, second line, and third line treatment, that's not working, how are you going to manage them?
I'm afraid we're still not anywhere near meeting a 48-hour treatment rate for these patients. So if, despite analgesia, we can't control their pain, our standard practice at present is to attempt a primary ureteroscopy, but unfortunately due to a number of reasons, availability of endourologist, availability of the laser, availability of the appropriately trained nursing staff, we're rarely able to offer that. So a lot of our patients currently end up with a stent and coming back in the next 2 to 4 weeks for a ureteroscopy. I don't think that's ideal practice, and we do need to aim to change that, but currently that's what most of our patients would end up with.
I expect the experience of many in the room. Wasim, what's it like for you in Hereford?
I echo Zara's thoughts. We are limited to one endourologist, one laser-equipped theatre, and we don't have the capacity or facilities to offer the 48-hour ureteroscopy. if this gentleman happens to come in over a weekend and he's starved on the Monday, there's a good chance he can get a primary urethroskopy as an addition to the list, but in reality, you'll be looking at a stent, and then we'll try and bring them back in usually 6 weeks' time.
Dickie, we've heard before about your real life data. So knowing the answer and that 48 hours was better sooner than the rest of us in the room, some of us even just today. How are you doing in Plymouth with acute ureteroscopy?
We're not doing it within 48 hours. We squeeze them onto our list during the week, and we have a designated emergency list on a Friday afternoon. What we have done, though, is that the outcome of what we've described as primary ureteroscopy, in other words, doing it rather than putting a stent in, is actually quite good. And it's mainly the registrars doing the list, so their success rate seems to be as good as mine, and they'll often do them with my supervision on the MDT. So though we're not achieving 48 hours, we have noticed that actually primary ureteroscopy may not be quite as difficult as we sometimes perceive. The number of people we couldn't do and have ended up in stenting was a couple. So they were interesting. It was an interesting small audit that we did.
So we've heard that it's a good thing to do. We've heard that it's difficult to deliver, but JG.
I'm just slightly confused because I understand that we're supposed to be offering primary lithotripsy, not primary ureteroscopy as our treatment of choice for the ureteric stone. But all the responses within 48 hours have been primary ureteroscopy. And can we just clarify that?
Yeah, that's absolutely true. But when you have a mobile machine that comes every 4 weeks, you can't do that. But we now have a business case and will very likely get a static lithotripsy in by the end of the year based on these guidelines, because I gave my trust slightly heads up, and also on the
Insider trading.
On the girth report, which also suggested that we are doing too many stenting and we should be doing primary treatment.
So it's difficult, but Rob, why is it right?
Okay, well, we'll talk first of all about the evidence on treatment choice, and then we'll come to the timing in a minute. As Dickie's already explained, it suggests that we should offer lithotripsy, but consider ureteroscopy if stone clearance is not possible within 4 weeks. So that's retreatment and maybe a salvage ureteroscopy if you failed, because we don't want to damage the renal units. And that also is logistical. So if you just don't have a lithotripter that comes in that time scale, you should ureteroscope them. So that is consistent with what the guidelines say for that. If we just move to the next slide, please. But the stone-free rate is different. So the stone-free rate shows that the success is better for ureteroscopy than it is for lithotripsy, and it was about, I think, 93% versus about 83% for stone-free rate. And it's also less retreatment with ureteroscopy. If we just move to the next slide, please. But the complications, the major adverse events, were fewer for lithotripsy. The minor adverse events were not significantly different, but were trending towards lithotripsy. And then we also looked at failed technology. So failed technology was either on an intention to treat analysis, you couldn't target the stone with lithotripsy, or you couldn't get into the ureter on ureteroscopy. So that's what that was about. And they were quite uncommon in the studies, actually, but if anything, it slightly favoured the lithotripsy. So Dickie's already given some discussion about the health economics of this decision, and this was the one instance in the guidelines where health economics trumped a stone-free or an efficacy rate, although you might argue that the complications and tolerability favour lithotripsy anyway. The reference cost for lithotripsy is £452. Now, it's not quite the same as the tariffs. Tariffs sometimes have incentives and things added to them. For ureteroscopy, I think it's 4.8 times higher. It's 2,172 or something like that. So it's very difficult, even with a really bad lithotripsy success, to make ureteroscopy more health economic. It's nowhere close in these analyses. And it is a guideline, and patient choice can still trump it. But the guidelines have to try and make decisions about resource use at a population level, and that's what it's come up with in this instance. You could almost make the same argument for larger stones, but the guidelines committee felt that for the 10 to 20 millimeter group, that the risk to the patient was higher. So that's why we haven't said that for the larger stones. So, open to discussion.
So you can see from all these are the data that are in the 1,700 pages behind. That's pretty clear what we should be doing. Smaller stones, shockwave lithotripsy. The results of tissue are not yet out, but that will clearly add further weight to that discussion. Shockwave versus ureteroscopy for stones of under 10 millimeters, larger than 10 millimeters, ureteroscopy over shockwave. Actually very similar to the joint EAU-AUA guidelines, so not that controversial. But what about the within 48 hours? We've heard that that's difficult, but what was the evidence that said that to treat within 48 hours is what we should be aspiring to?
Okay, so if we just move on to the next slide. So this came as a little bit of a surprise to us. There are 3 papers that randomize this. There's nothing else looking at timings, and the patients in the panel thought it was very important to try and have something that stopped patients around the country being stuck with stents for 3 months. And this is what the evidence showed. So there were patients who were recruited to these trials were patients with ureteric stones less than 10 millimeters in whom a decision had been made to intervene. And one of them was a ureteroscopy treatment, and the other 2 were lithotripsy, and they looked at early treatment versus delayed treatment, and the timescales were slightly different between them. One was before and after 15 days, one was before and after 48 hours, and one was before and after 72 hours. And what they showed that the stone-free rates trended, although not quite significant, towards better for the early patients, but certainly the ancillary procedures, the retreatment rates, and for the ureteroscopy paper, the stent insertion rate was much better in the early group. Now, we think this is probably because of edema. We don't think it's because of a over-treatment, so treating stones before they were going to pass anyway, because the number of stones in the delayed groups that had passed was actually very small in this, so they did genuinely look like they were patients that needed treatment. But we think it's probably ureteric edema, so if you can get on and treat the stone within 48 hours, you're likely to have a better success rate, much lower stenting rate. I mean, for the ureteroscopy one, it was 20% versus 80% was the stenting rate. So it does genuinely seem to confer an advantage to patients, which is why this recommendation has been made. It is difficult to deliver. It is, indeed. And it may mean that we have to look at more lithotripters around the country. That will affect the reference cost, because the reference cost does take into account the cost for average lithotripsy, including the cost of the machine. So it will push that up, because if you're doing fewer treatments per machine, each machine is going to be more expensive. And it may also require networking. So GERFT are pushing urology area networks, and it may be that a hospital that doesn't have a lithotripter may have to have a rapid referral service or arrangement whereby patients come across and have lithotripsy. But ureteroscopy is still an option, and I don't know whether you want to discuss the logistics of that further down.
Oh, well, that's well timed. JG.
So, all ready with your phones once again for the next question. Definitive treatment of a ureteric stone within 48 hours of presentation is already the current standard in our hospital, is achievable with minor service configuration, is achievable with considerable service configuration, or seems unachievable without significant resource implications. So we need your questions, please. The app should be working fine now. So it looks like the NHS is going to have to be reconfigured.
Never a truer word has been said. We've reconfigured our service. We're now doing more primary and early ureteroscopy. What about leaving the patient without a stent? We're on a roll with the audience participation. Keep going.
So just 2 seconds. So do you usually stent after treatment of a 1.5 centimetre ureteric stone treated ureteroscopically in a previously unstented ureter? So that's like that question has gone live. Just to let you know, audience, that we've got over 100 people answering the questions, so keep going. We're up to 150 now. So lots of you are taking part, so thanks very much. That was true for the last couple of questions we've posed. And
so the majority
stent. So go back to that evidence. So we have been asked by NICE to completely change what we're doing, from what I understand. Do you routinely stent for a 1.5 centimetre stone in a previously unstented ureter? And we're assuming this is the uncomplicated patient.
So most of us do. We showed that in an article a few years ago that even when it was actually really quite reasonable not to, still most of us still do. But Dickie, you don't, and you haven't for some time. So before we get Rob to talk about the level 1 NICE graded evidence, what is the Dickie Journal of Personal Experience in Plymouth evidence? Because we like that too.
Yeah, no, I don't stent these patients. The only ones I do stent is if they've been hydronephrotic and there's a bit of a worry about sepsis afterwards. I haven't noticed, anecdotally, them coming back with a significant problem. What are you stenting? Why are you stenting it? We know that stent obstructs the kidney. It doesn't allow stone passage. So if you've dusted that stone, those bits need to come out. Why are you stopping them for a week to 2 weeks by putting a stent there?
We certainly know that stenting prior to shockwave makes the fragments not drain. So that's a reasonable argument. Rob, what's the actual evidence?
Okay, so we just move on to the next slide, please. Yeah, so these slides just look at the less than 10 millimetre group, first of all, which is perhaps less controversial. We know from the BAUS ureteroscopy audit that the stent rate was about 70% around those who submitted data. It doesn't appear to have an effect on stone free rate, the stenting, and it doesn't really appear to have an effect on length of stay. In terms of readmission in the randomized trials, so the randomized trials they all had slightly different criteria, but the theme was that in uncomplicated patients where the decision is usually made intraoperatively, they'd be randomized to stent or no stent. And the criteria for what is uncomplicated did vary somewhat between the trials. But we've discussed some of the main things. The readmission rates on the meta-analyses were not significantly different, but there was a trend to more readmission in the unstented people, but the numbers were small. So it was about 1% readmission in the stented group and about 3% in the no stent group. Next slide. But what we do know, and Rishi Joshi's data, although this shows that there is a lot of stent-related symptoms. Now, looking specifically at the randomized data, the dysuria was very much less in the no stent group, as was the hematuria symptoms. So stents are uncomfortable, and yes, you might have a very small number of more readmissions, but that's what the data has shown. The 10 to 20 millimetre data, which we haven't got slides for, have we got? I think. No, I don't think we've got the slides for those ones. It is similar, but the differences are slightly bigger, as you would expect, and the numbers are smaller.
So we'll leave the ureter there. We'll park that one. We'll move to the kidney. For Wasim and Zara, these are patients that you've known for some time. They trust you, and they're asking you, you know, I don't want a whole range of different options and choices. I want you to recommend me your first-line choice for me, and then tell me why you've chosen that one treatment. Wasim, 11 millimetre stone, 1,300 Hounsfield units, sitting nicely in the renal pelvis. What are you going to recommend that I have for that?
Darren, I would recommend you have a flexible ureteroscopy. As we saw yesterday with Dr. Gani's presentation, modern-day lasers, modern-day ureteroscopy, dusting mechanisms, your stone-free clearance rate in one go is going to be high. And I'd explain to you that, you know, if you mention the word lithotripsy, it's possible, but we're talking at 1,300 Hounsfield units. We know the kind of critical number is about 975, so it's quite a hard stone. You're going to need a good few sessions, where I'd be very confident that I could probably get you stone-free in one sitting, and if it does beautifully, I'd even leave you without a stent.
Nice. I trust you. I'd have that. I'd buy it. I definitely would. But my wife tells me I've got to go and get a second opinion. So I always do what she says. Zara, do you agree with that?
Yes, I do. I would offer you a flexible ureteroscopy as well. I would discuss all three options as I see it. So I would discuss the option of lithotripsy, but as Wasim said, that would almost inevitably involve multiple visits. And there is a risk that it wouldn't fragment, but some patients would prefer to go for the least invasive option first, so I would certainly offer that. And I would also mention a mini PCNL. I know that's not within the NICE guidelines unless they'd failed other options, but to my mind it offers the best chance of complete stone clearance in one sitting. And mini PCNL, tubeless, without a nephrostomy, a lot of the concerns about length of stay and complications are referring to standard PCNL rather than a mini PCNL. So I would offer it, but my recommendation, if they asked what I would do, would be for a flexible ureteroscopy.
So just behind your head, I've moved the slide on. I've made the stone a little bit bigger in its individual dimensions. Of course, that affects its volume. So we'll stay with you. It's now 13 by 12 by 15 millimetres. It's also in the renal pelvis. So that one perhaps slightly more friendly for a super mini perk as this was. So in your opinion, this would seem reasonable. So that's good because I've already done it. And then we'll make it just a little bit more for Wasim, a little bit more complicated still. And then we'll have Rob say whether these were reasonable decisions on my part. So it's a slightly bigger stone, again, that's got 3 separate stones in separate calyces. So it's just, you know, this is real life. It's getting a bit more complicated. What would you recommend that I do for this one?
I'd give you 2 options. I'd give you what I could offer you, and I would also tell you that there is another centre which maybe offers you something different. So I'd counsel this patient again that with the modern day lasers, fibroscopes, there is still a possibility of being cleared in one go, possibly 2. You will probably have to have a stent in if you want to be looked after locally. But again, it's down to patient characteristics, patient fitness. It's a completely viable option if they wanted to have something like a PCNL for this case.
So that's also a relief because that's what we did for this one too. Maxi perk so that we could have put a flexible scope in and clear it all in one go. Rob, tell us now, these are obviously historical cases. Were these reasonable decisions in light of the evidence for NICE, Zara?
Before Rob gives the evidence, could I say what I would do in that case?
Oh, yeah.
You know the answer now.
Well, I know Darren's done a standard PCNL. I would offer a mini PCNL with a lower pole puncture, but a combined intrarenal surgery. So obviously the issue with a mini perk is that you wouldn't be able to get around the corner to those 2 interpolar stones. But using a flexible ureteroscope, you could access those 2 small fragments and hand them out through the lower pole mini perk access.
Very nice. Rob, the evidence.
Okay, well, the evidence doesn't look at multiple stones because there's too many combinations of multiple stones, so there aren't randomized controlled trials for multiple stones. So that is a weakness of the guidelines because quite a few patients do have multiple stones. probably at least a third. But looking at the single stones, and looking at the 10 to 20 millimeter group, the guidelines suggest that we should consider FIRS or lithotripsy, but consider PCNL as a second line. So if we just move to the next slide. So looking at the stone-free rates, for these size of stones in the randomized controlled trials that we have, and bear in mind there's different definitions of stone-free rate within this, and they're not all CT stone-free, there wasn't a significant difference. And the retreatment rate also wasn't significantly different in the evidence that we have. And on the next slide, it just shows you the adverse events. And again, there was no significant difference, but maybe slight trends towards less problem with the FIRS. So that's what the evidence we have. We also know there's health economic data because the cost of shockwave lithotripsy, the cost of PCNL, the way it's delivered on average in this country is about 2.5 times more expensive than a FIRS. I suspect the way Sarah does a mini perk is probably a lot cheaper than the average in the country, but that's what the data they have to work with and model with.
Thank you. So this is now the last case, as I said at the beginning, and as Dickie has already said, the large stone is much less contentious. A big patient with a big stone, treatment strategy, Zara, then Wasim.
So I would offer this patient a standard PCNL with the lower pole puncture. I don't routinely leave a nephrostomy afterwards. I probably in this, but with any staghorn stone, there'd be a concern about drainage, so I would probably stent this patient afterwards. I'd do a supine standard PCNL.
Wasim?
I can offer anything for this gentleman at my centre, so it's sometimes good to know where your limits are. I completely agree with Zara. This gentleman does need a PCNL. It's not doing the PCNL sometimes, it's the aftercare, and when things go wrong, we just don't have the kind of middle grade and neurology cover. So I would probably refer this patient to somewhere that could offer them a supine PCNL.
So the evidence for that, it's a perk, isn't it? It's a big stone, it's a perk.
Okay, yeah. We'll just move to the next slide, please. So there were two groups here that were looked at. One was the non-staghorn stone more than 20 millimeters, and that's where the randomized evidence is. For staghorns, which this stone was, there are no randomized controlled trials that were within the search parameters of the study. We, during the scoping, the decision was made to not include open surgery, and we know that the numbers of open procedures for stones around the country have dropped to almost single figures, so they are very rare. There is a randomized controlled trial from about 15 years ago from Mansoura, and they struggled to make open surgery, even with their large experience, look better than PCNL. So for staghorn, there was no evidence, and so this was an opinion of the committee members. For the 20 millimeter stones, though, and above, and most of these stones in the studies were randomized were less than 30 millimeters, although some were a little bit bigger. There wasn't a great difference in terms of stone-free rate between PCNL and FIRS. And the retreatment rates were not very different. There's only a small number of studies and not that many patients included. But I think after discussion, well, if you look what we've said, that consider URS if PCNL is not an option, and that tends to be for the stones where the patient is perhaps not fit for a PCNL, or there may be other anatomical factors or anticoagulation, and the stone's only just a little bit more than 20 millimeters. And I think that's what we sort of meant with that indication. You could do it in selected cases.
So as Dickie said, these are for follow-up and metabolics, more for the enthusiast, follow-up for all of us, but we don't really know. So I'll skip over that. I'll skip over that just because we've got a few minutes, and it would really be a travesty with a panel like this not to have perhaps one or two questions. I don't know if we've got a raving mic. You may just have to shout out. I'll be able to. Here we go. Here comes a microphone.
Thank you, Azat Hawazi from Ipswich. You say offer ESWL to stones in the ureter, but you didn't specify density. Does that mean we should offer it to every stones, regardless how dense they are?
Yes, is the answer from NICE, because there wasn't any evidence that doing any other X-ray density makes any difference. That might be the case, but when you've got the number of papers we looked at, you can't break it down into these tiny things. You have to give a general opinion. So the answer is yes, offer lithotripsy.
Anthony.
Anthony Timley, Bristol. So I'm somebody who doesn't tend to stent large, uncomplicated ureteric stones. But somebody who presents and is having a hot ureteroscopy within 48 hours of presentation, I'd regard that as complicated. And I would tend to stent them because I'm worried about edema around a big stone. I know the NICE guidance doesn't subdivide with that, but I'm asking the panel, what would their view be of a, say, 15 millimetre ureteric stone within 48 hours of admission, if we get there?
So, sorry, go on.
I was going to say, I don't routinely stent at any ureteroscopy except for solitary kidneys or in the presence of sepsis. But I would always counsel every patient having a ureteroscopy that decision would be made at the time of the ureteroscopy, depending on the appearance of the ureter. So if in that case we managed to do it in 48 hours, which, as I say, in my hospital is a rare occurrence, but if we did manage to do it in 48 hours and there hadn't been a huge ureteric reaction and the ureter appeared not to be particularly edematous, then I would be happy to leave it stent-free, as long as I say, there was no evidence of sepsis. But in my practice, we're tending to, in patients whose pain is controlled, discharge them home and bring them back in whenever we can, which tends to be 2 to 3 weeks. And by that stage, in my experience, most of the ureters look fairly horrible. The stone's quite impacted, the ureter's very inflamed, and so in most cases, these sort of semi-hot ureteroscopies, I am stenting because the ureter doesn't look as if it's going to drain adequately without a stent. So I think that comes back to what we were talking about the timing.
Individual choice, on the basis of the patient. JG, probably the last word to you, sir.
It may be that London patients are different from Plymouth patients, but I must say, if I have a patient in pain, I want them to wake up without pain. And it is my experience that if you don't put a stent in, they often wake up in recovery, rolling around in agony, and getting that pain under control for the first 48 hours seems to be a challenge. And with a stent in, that seems to be less of a challenge. I constantly learn, and I'm constantly looking to change my practice. But that's personally my experience, and it may be that I'm wrong, and I'm very willing to have the discussion, and maybe I should try not stenting more. But I think to see a patient who's gone into theatre within 48 hours in pain, I want them to wake up out of pain, and a stent seems to do that for me.
I think probably if there's anyone in the country who could have a patient wake up after a ureteroscopy, have a dance in their national language, have their name pronounced correct, and get up to a quality of life score of 28 after a ureteroscopy, JG, it would be you who could do it. For the rest of us, a big thank you to the panel. I'm sorry we can't have more questions. There will be loads. Everybody's around. Come to the poster session this afternoon, grab them and ask them, because there's another session that is starting now, so I think we have to vacate and you all guys have to go elsewhere. Big round of applause for the panel. Thank you very much.